This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation.
Today's case is...
The patient is a 35-year-old female with an unfortunate history of AIDS, ESRD, and lupus.
You recognize her as someone who comes 3 times a week for dialysis.
In interviewing her, she states that in addition to her usual symptoms, she has had a ground-level fall this morning and has been having chest pain and shortness of breath since then.
You add on a chest x-ray and cardiac markers to your typical dialysis labs.
The x-ray tech takes the patient's portable chest x-ray and walks out of the room to notify you that the patient is now minimally responsive and noted to be profoundly hypotensive.
One useful tool to evaluate shock in the undifferentiated hypotensive patient is the rapid ultrasound for shock and hypotension, or RUSH exam.
The RUSH exam utilizes the acronym HIMAP as a cognitive prompt for the views needed. That is, heart, IVC, Morrison's to remind you of the FAST exam, aorta, and pneumothorax. One useful way to consider the causes is to think about the pump, the tank, and the pipes. The RUSH exam helps eliminate some of these causes from the differential.
The pump is the functioning of the heart. With bedside ultrasound, the pump can be evaluated by looking for pericardial effusion, evidence of tamponade, right ventricular failure as a sign of pulmonary embolism, and qualitatively, the left ventricular function.
The tank is an examination of blood flow and involves evaluating the IVC for volume status, the abdomen and chest for evidence of peritoneal or pleural-free fluid, and the lungs for evidence of pleural effusion, pulmonary edema, pneumothorax, or empyema.
The pipes are the vessels themselves and can be evaluated by looking for DVTs and at the aorta for evidence of aneurysm or dissection.
In this patient, the chest x-ray is still pulled up on the portable machine and shows significant cardiomegaly concerning for pericardial effusion, which in the setting of hypotension suggests tamponade.
With tamponade, ultrasound findings include rapidly accumulating small pericardial effusion or a large effusion, early diastolic RV collapse, late diastolic atrial collapse, exaggerated tricuspid and decreased mitral diastolic inflow on inspiration, and dilated IVC with no variation with respiration.
Here is the patient's ultrasound. The ultrasound shows a large pericardial effusion with complete collapse of the right ventricle and diastole.
Electrical alterance can be seen on EKG and pulsus paradoxus on exam as well.
Cardiac tamponade is a medical emergency requiring urgent drainage of the pericardial fluid.
Patients should be placed on oxygen, given volume expansion with blood, plasma, dextran, or isotonic sodium chloride solution as necessary to maintain adequate intravascular volume, and bed rest with leg elevation to increase venous return.
Positive pressure mechanical ventilation should be avoided, which can decrease venous return and aggravate signs and symptoms of tamponade.
Classically, cardiac tamponade is characterized by Beck's triad of JVD, hypotension, and muffled heart sounds. But this is only present in 40% of patients with tamponade.
There are a number of causes of pericardial tamponade. In our patient, kidney failure, chest trauma, and lupus can all put her at risk for developing tamponade.
How much fluid in the pericardial sac is needed to cause tamponade depends on the cause. Slow increases in fluid can gradually expand the pericardial sac to contain more than 2 liters of fluid. However, a rapid development of as little as 200 milliliters can cause symptoms.
In the developing world, tuberculosis is a relatively common cause of pericardial tamponade.
Symptoms of cardiogenic shock, including shortness of breath, weakness, lightheadedness, and cough, can occur.
As pericardial tamponade is a medical emergency, quick action is necessary. At minimal, an 18-gauge spinal needle and a syringe is all that is needed to perform a pericardiocentesis.
If there is time for preparation, in addition to the needle and syringe, EKG wires with alligator clips, a guide wire, a pigtail catheter, a dilator, a stopcock, local anesthesia, sterile drapes and wipes, and your trusty bedside ultrasound should be used.
Though there are a few ways to approach the pericardium, the standard approach is subxiphoid.
In the blind approach, the provider stands on the patient's right side, the area is prepped and injected with local anesthesia. The needle is inserted at an angle of 30 to 45 degrees to the skin, aimed at the midpoint of the left clavicle, 1 centimeter below the left xiphoid-costal angle.
The heart is pretty anterior, so any angle greater than 45 degrees is too much and makes you more likely to puncture the stomach or liver.
If the first advance fails to produce any fluid, withdraw the needle to just below the skin and redirect it a little bit more medially.
Under ultrasound guidance, which is the standard of care, the more common approach is the apical approach.
With ultrasound, identify the apex and insert the needle 1 centimeter lateral to this with the point directed towards the patient's right shoulder. Visualize the needle point under ultrasound and advance into the pericardial sac. As the lincula lies close to the apex, this approach risks causing a pneumothorax.
A third option is the ultrasound-guided parasternal approach, in which the needle is advanced at a 45-degree angle towards a well-visualized pericardial fluid collection under parasternal long axis view. This avoids the drawback of puncturing the lingula, but care must be taken to avoid the internal mammary artery.
In both approaches, make sure to avoid the neurovascular bundle on the underside of the rib, set flat to your point of exertion.
Although most references cite a drainage of 60 milliliters of pericardial fluid is sufficient to improve patient status, an indwelling catheter can be placed using a Seldinger technique to allow the pericardium to continue to drain.
Post-procedure, the ultrasound can also be used to confirm reduction in the effusion, a lack of right ventricular free wall collapse, and a normal IVC response to respiration.
To summarize, ultrasound can help in workup of the undifferentiated shock patient.
The rush exam, which utilizes the acronym HIMAP, or Heart, IVC, Morrison's Pouch to remind you of the FAST exam, aorta, and pneumothorax can help narrow down the differential.
Think about the causes of shock as pathology affecting the pump, the tank, or the pipes.
And when suspecting cardiac tamponade, know how to proceed with the pericardiocentesis. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou.
Thanks for listening.